Hello, and welcome to the 2020 virtual panel session, Keys to Success for Employed Surgeons. I'm Jay Lieberman. I'll be your moderator today, along with Chris Senkowski, your co-moderator. We are pleased and privileged to be able to present this information to you today. We've chosen 3 topics that we think are important as more and more physicians, surgeons translate into a employed surgery model. Data suggests that up to 50% or more surgeons today are in employed models. And if you look at younger surgeons or surgeons particularly that are right out of training, that number is even higher, maybe even 65 or 75%. And we would extrapolate this to say that in the next 10 to 15 years, certainly the next 15 years, that the majority of surgeons will be in an employed model. So these topics we're going to talk about tonight, RVUs. I'll talk a little bit about RVUs and why we have them. Wayne Hartley is from the American Medical Group Association. He is certainly a national expert in fair market value. And Ann Bittinger is a health care attorney in Florida who specializes in employed physician contracts, and she takes clients from throughout the country. She's also a national expert in employment contracts. And then for a few minutes at the end, we'll have a Q&A with Dr. Senkowski. So what exactly is an RVU? It's certainly not a measure of payment, right? It's not like cash. You don't put it in your wallet and go down to the coffee shop and pay for pay for your coffee and donuts with RVUs. That's for sure. Before we go into what an RVU is, let's just talk for a second about why we have RVUs. Prior to 1992, physician payment was made by usual, customary, and reasonable rates. You submitted a claim and it was paid. And that led to variation in compensation by region, by specialty, and by the amount in it, not by the resources utilized, which was the issue. And it led to an unchecked increase in compensation. So the government said, this is not good. They approached a group at Harvard and said, we need to fix this. And the Harvard group came up with a resource-based relative value scale, or RBRVS. Basically, what that does is remove the price of services from medical decision-making process. And it says that the payment for physician services should vary with the resources utilized to provide those services. So a level 2 E&M code should be valued less than a level 3. A level 3 E&M code should be valued less than a lap chole. And a lap chole should be valued less than a craniotomy. And that's the current payment system that's used by CMS. So what are the components of an RVU, a relative value for unit of work? There's work, there's practice expense, and there's professional liability. So there's the equation. Total equals work plus practice expense plus professional liability. So what is work RVU actually? So CMS defines it as a typical patient, the amount of work that you put in for greater than 50% of your patients, your average patient. So for lap chole, it'd probably be your biliary dyskinesia patients, your symptomatic cholelithiasis patients, patient who needed a lap chole after an ERCP for choledocholithiasis. And the resources are everything that you think should be in there: time, effort, skill, and intensity of the case, mental effort and stress, and they even amortize your training expense, believe it or not. Not very much, but it's there. So work is actually separated into 3 components in and of itself. And there's a pre-service, and that's anything that you need to do to get the patient to the operating room. You review the records, you communicate with consultants, dressing, scrubbing, and waiting, prepping, believe it or not, and positioning. So you're spending time putting a patient in the stirrups for an APR. That's in the work RVUs. Skin to skin is intra-service. It's pretty straightforward. Anything you need to do between the beginning and the end of the operation. And post-service is anything that's provided within the global period, be it 90 or 10 days. Practice expense is the cost to run the medical practice, the facility, hospital and sites, or non-facility, which is the office. And professional liability RVUs are just that, the cost of medical malpractice insurance for the physician and their practice. So here's the equation again. And CMS identifies that there are geographic differences. So they apply the GPCI, or the Geographic Practice Cost Index, to these RVUs. And it identifies that lap chole is certainly more expensive to perform in Manhattan than it is in the north of Vermont. And then the conversion factor is also set by CMS, which converts RVUs into real dollars. In 2020, it was $36.09. In 2021, it's supposed to go down to $32.26. And that is not a typo. That is, as we tape this, that is what's supposed to happen. So here's the equation: work, RVUs times work, GPCI, professional practice expense times practice expense GPCI, and professional liability times professional liability GPCI times a conversion factor equals a total RVU. So you have lap chole, excuse me, 19.0 for total RVUs. In 2020, you would get $687.15. In 2021, it's supposed to go down to $614.23. Again, it's not a typo. This is scheduled to happen. Here it is on a slide. Colectomy, this is 2007 numbers, not relevant. It's just the concepts. The practice expense in San Francisco is 1.458. In Little Rock, it's 0.0847. So it's much more expensive to practice in San Francisco. The professional liability GPCI is 1.240 in New Orleans, more than it is in San Francisco. So it's saying that New Orleans is more litigious in 2007 than San Francisco. So how does an RVU actually even come into being? First of all, you need a CPT code. You need to have something to attach it to. So let's say prior to doing endovascular aorta repair, there was no such CPT code. So once it became the standard of care, not inferior to open aorta, the ACS, the SVS made the petition of the AMA CPT panel to have a CPT code. There are 2 people in the college that represent the 70,000 fellows to get these new codes made. Once the literature supports the procedures, the codes are made. So then AAA endovascular repair had a CPT code. After it's made, it's sent to the RBRVS update committee. That would then attach a RVU value to the CPT code. And basically what happens is we would petition the RUC and we would make recommendations as to what the RVU value should be. And the way that is done, actually, is that these specialty societies, the ACS or the SVS, would send out a survey to at least 30 physicians who actually perform the procedure and ask them to estimate their time, the work RVUs, compare it to other surveys, and for a reference procedure, and come up with an RVU that they think. The RUC would then say, we think it should be X number of RVUs, go to CMS, and CMS would say, yeah, we agree, or we don't agree. That's basically how a CPT code, a procedure gets a CPT code and then gets an RVU value attached to it. The last slide I'm going to show you, the last 2 slides, are about the conversion factor and what we talked about a little bit earlier. It's 36.09 today, and it's supposed to go down to 32.26 next year. That's a 10.26% decrease, and that's below the 1994 conversion factor. If that went up according to inflation, it would be $58.02 today. It's crazy to think that the payment is going to be that much lower in today's dollar. And it's going to impact even employed general surgeons. Maybe not the day it happens, but it will impact us down the road. What you can do, you can send a letter to your members of Congress utilizing Surgeon's Voice. You can schedule a meeting with members of Congress utilizing the ACS platform. This is all on the ACS website. Encourage your colleagues to do the same and involve your partners. And most importantly, raise your voice, talk to your Congress people, and let them know you need them to intervene to stop these Medicare payment cuts. This outreach will make a difference in how legislators prioritize the issues. Thank you very much, and I look forward to hearing the rest of the presentations today.